few weeks ago, I was invited to participate as a shared decision-making expert in the National Quality Forum, and they brought together several scientists in this area. And they've come up with 3 key components for shared decision-making that need to be part of this discussion. The first one is evidence itself that should be unbiased and that should highlight the advantages and disadvantages of available treatment options to each of the patient. The second is the clinician sharing his or her expertise. And finally, including patient values in that decision-making process, whether it's an overt elicitation of those values or an implied application of those values to a decision. And those who are familiar with shared decision-making may find this definition not surprising. But it's actually been involved in various studies led by other investigators in which it's actually not as intuitive as it appears, even though it's simple to understand. There's a study that I'm involved in called the E-Track study, which is called Empathy to Reduce Unnecessary CT Use. And it's based on the hypothesis that if clinicians can interact with patients and more effectively induce empathy, it will increase trust, and they'll trust the clinician's assessment more than the test itself. So we've had some discussions with Patient-Centered Outcomes Research Institute, and it's like, okay, where's the evidence as part of this discussion? That may be a true hypothesis, but it doesn't actually meet definition for shared decision-making because it doesn't highlight the different options the patients have before them. There's an ongoing systematic review that's been updated several times. It's produced by Don Stacy and colleagues at the Cochrane collaboration. And we found that over time that decision aids have been shown to have these generalized direction of effects for each of the major outcome categories. They've been shown to increase patients' knowledge, increase the accuracy of their risk perception. This is the one that really stands out to me as my interest in clinical prediction rules. Can we increase patients' accuracy enough that they can meaningfully participate in diagnostic decision-making? To decrease patients' uncertainty related to choosing among options for which they're uninformed. In some cases, it decreases a major elective surgery, and this is true in the case of prostate-specific antigen screening and prostate surgeries. So this is a summary of the methods that our group here has used over time to develop multiple decision aids. And this slide actually, I think I got from Annie LeBlanc, who's sitting in the back there. So we start off with an evidence synthesis or a systematic review to identify the prediction instrument that's of the greatest use in this particular clinical situation. We then pull together multiple key stakeholders, including patients and clinicians and other investigators, and with the help of a designer, we design an initial prototype. Then we take that into the clinical encounter and just see if it works or not, and get authentic and direct feedback as to how can we actually use this to facilitate a discussion and a meaningful conversation with patients. And we go through that process multiple times until we start to hear the same themes over and over, and we feel like, okay, we've incorporated the feedback that we need to, and then we test those decision aids into trial. And if you just type in National Shared Decision-Making Resource Center into Google, the first hit will be the Mayo Clinic National Shared Decision-Making Resource Center, and you can hit the list there that has all the decision aids we've developed over the last 10 to 15 years, Victor. It's kind of scary. Makes me feel old.
Just you.
Okay, thanks for leaving me out in the cold there. I appreciate it. But the 2 that I'll be highlighting today will be chest pain choice and head CT choice. Does anyone know what this is? It's this drop. Does anyone recognize what this is? Blurt it out if you recognize it. This is the. I'll give you 10 seconds. That's the amount of duration. Yes. Okay, it's in Salzburg. Okay, you got an easy clue. This is the Salzburg Global Seminar, and it was formed in the 1940s and 50s in the wake of post-World War II Europe. And the purpose of it was founded by 3 different individuals, 2 Americans and an Austrian. And the goal was to revive intellectual dialogue in post-war Europe, in which human dignity had received one of its greatest defeats in light of the Nazi regime. And it was in 1998. The topic of discussion was, what does it mean to treat humans with dignity and respect in the context of healthcare? And that's where Valerie Bingham was credited with first coining the phrase, nothing about me without me. Nothing about me without me. And if you actually just go into Google and type in that phrase, it has over 10 million hits. and it's in multiple different contexts. And if you click on videos, there's videos of things that are completely unrelated. So they've stolen the idea, applied it in multiple contexts. This is another gentleman named Brian Zink. And I highlight Brian's work largely because the group of people that I am really trying to influence to engage patients in shared decision-making are largely emergency physicians. And Dr. Zink is professor and chair at Brown Department of Emergency Medicine. And a few years ago, he took a year sabbatical. And he came and gave us a grand rounds 2 years ago. And he has like multiple like authentic first-person interviews of the people who were around when emergency medicine first started as a specialty. And these are like not like easy mamby-pamby type people. This is the people who are like strong alpha males and females who had to make things happen, who are yelling with surgeons, like there's like F-bombs dropping everywhere through these interviews. Like these are like people that are not exactly PC but had to be around if they wanted to start something new. And the story that he told us prior to the 1960s, if you were to train in medicine, it was really common to just do your medical school in 1 year of training in the United States. And that was a generalist position, and generalists would pick up multiple things and just learn on the fly. And if you ever interact with some of the older physicians, and it's like, you know how to do a colonoscopy, how do you know that? You're whatever, it's because that's how they just picked it up and figured it out. And in the early 1960s, however, that's when specialty training became more popular in the U.S. So you had ENT physicians, oncologists, GI surgeons, and as the specialties rose, then hospitals actually used that to grant credentialing in the hospital. And so what that actually happened is that hospitals became the technology healthcare delivery hubs. And if you wanted the latest care, you had to go to the hospital. And around this time, there was a gentleman named James Mills. He and two people in Alexandria, Virginia, conducted what they called the Alexandria experiment. And they said, forget this, we're generalists, but we're going to go figure it out our way in the hospital. So they packed up their bags, they closed their office practices in Virginia, and they just started working in the ER. That's back when it was a room. And these movements started around the country, and they were purported to be successful type movements. They started to meet nationally. That was the first formation of the American College of Emergency Physicians. And in the early 1970s at the University of Cincinnati, there's a guy named Herbert Flessa who was on the hospital board at that time. And at that time, it had become really a big social problem. There was over 100,000 patients per year that were flocking the emergency department. And you need to figure out who's sick, who isn't sick. And Herbert Flessa was like, okay, you're on the board, your problem. You got to go figure out this problem in the ER. It's like, okay. So he went down there, pulled down some people, and that's when he actually found there was a key need to train people to be able to differentiate the sick from the not sick. And one of the key elements of the formation of emergency medicine, it was really formed in response to meeting a humanitarian need. Yes, there's a subspecialty area of expertise, which is identifying who's really sick and who's going to die soon. That is a content expertise, but in general, it arose from a humanitarian need. And it's this really this commonality between emergency medicine and the shared decision-making movement that I've really highlighted over time that motivates me as to why we should include patients in decisions. Okay, and Victor alluded to, okay, this is the emergency department. What the heck? You don't have any time. There's people flying all over the place. There's beds in the hallways. How's this going to work? And so one area that we chose to look into was the second most common reason patients show up in the emergency department, in which patients with chest pain, most of them, are chest pain free during their evaluation, and you can actually carry on a conversation. And there also have been multiple prediction models developed for chest pain, and so I thought, well, let's figure out how to engage patients with the second most common condition in shared decision making, and see if we can make it work. And chest pain is a tricky thing. Despite all of our testing, approximately 1% of patients are inappropriately discharged and have adverse outcomes or misdiagnosis of myocardial infarction. And physicians know this, and so we have a really low threshold for testing patients regardless of their risk, and so there's a discordance between the degree of risk a patient has and the intensity of their testing. And this results in false positive tests, unnecessary downstream procedures such as angiograms and stents, and increased cost to patients in the healthcare system. And I'm going to take a bit of a break, and rather than describe in more detail our instrument itself, just show you an example of its use. Cecile. Good to see you again.
Good to see you too.
How are you feeling?
I'm feeling better, but still concerned.
So I'd like to just summarize what's happened so far, give you some insight as to why we do things, as well as talk to you about some next steps.
Okay.
We've put together this decision aid for you.
Okay.
Okay, so that I mentioned earlier, we're going to focus on next steps. Your initial evaluation told us two things. First of all, we can focus on your heart. And second of all, our initial results are reassuring.
Okay.
Okay. So that's where we are. So the standard here is to make sure you haven't had a heart attack. We'll need to do 2 more blood tests in the next 5 hours.
Okay.
Okay.
I'll stay here and do, okay.
Right.
Blood tests.
And what we'll be focusing on now is after those 2 blood tests have been drawn, and presuming they're also negative or reassuring,
Okay.
what would your next step be? Okay, that's what we're going to talk about now. Okay, so the next possibility to consider would be a stress test. And our stress test, like after taking all the blood tests, we can tell you confidently that you have or have not had a heart attack.
Okay.
But we're not able to tell you what is your future risk very well. So this stress test will help refine what your risk of a pre-heart attack is. So based on 8 characteristics such as age and gender and so on that are specific to you,
Okay.
we can tell you what your risk of a heart attack or a pre-heart attack in the next 45 days is.
Okay.
And that's what this shows us.
My risk.
Your individual risk.
Okay.
It says of every 100 people with factors like yours, 4 people had a heart attack or a pre-heart attack in the next 45 days and 96 did not.
Okay.
This is a picture that shows you the same thing.
That's, just knowing that is very reassuring. I feel good about that. Okay.
Yeah, good. Good. So that's our situation now. And so we have 4 treatment options for us, and they're all listed here, and you'll get a chance to read them
Okay.
once I leave the room. Okay? So the first one is after you've had those 2 blood tests, you just want to hop on the treadmill and get the stress
Here.
Here.
Okay.
The second option is once you've had those 2 blood tests that they're not normal, that we could arrange an appointment with a heart doctor here in the next 72 hours, next 3 days. The third option is if you would prefer to see your own primary care physician, but it would make me feel better if I knew you could see your own doctor within 3 days.
Okay.
And if you choose that option, I would probably still provide you the appointment as
Just
a
in case
backup.
I couldn't see my doctor. Okay.
Right. And then this has been a long day, and this is something that just rather have me make the decision for you. And if maybe you don't feel like you have sufficient staff support or whatever you need to make the decision right now.
Okay.
So those are our 4 options. Why don't I'll give you a chance to contact one of your family members.
Okay.
Understand that you're right now you're trying to get to call them.
Call my husband. Yeah.
And then I'll come back in a few minutes once you've had a chance to read through this and talk with your
Okay, great.
husband. And then we'll go
And
from
then
there.
make a decision.
Yeah.
Okay. Okay, that sounds good.
Okay, great. I'll be back in a few minutes.
Okay, sounds good.
So that's about the amount of time it takes to have this discussion with the patient. And I'll describe later, we actually videotaped discussions about the intervention and control arms of our trials and can tell you how long that discussion takes compared to the amount of time physicians normally talk with patients. So we tested the effectiveness or the efficacy of this intervention in the single center trial here first in Mayo Clinic, Rochester. We found some similar effects as the effects of decision aids that I highlighted earlier. So it increased patients' knowledge. Their clinicians made more efforts to engage patients in the decision-making process. We decreased our admission rate to our observation unit for stress testing by nearly 20%, and that maintained within 30 days, and that was a 16% lower rate of stress testing. Within 30 days was a significant difference. 2/3 of providers said that they would prefer to have other tools for similar conditions and to interact with patients in a similar fashion, and patients more frequently opted for outpatient follow-up. Finally, there were not any adverse events in either arm of the trial. And so based on these preliminary findings, we applied to test our decision aid more broadly And we have several co-investigators with us. In addition to Victor, we also have Annie Sadowski, Annie LeBlanc. I don't see any other co-investigators. Oh, actually, I see Maggie Breslin back there. She was involved in our initial trial, so we have it's pretty much a team effort. So we tested our trial across multiple sites. So we randomized patients on a 1-to-1 ratio using a web-based form that concealed allocation. And we took into consideration the patient's age and their gender and incorporated that element to ensure that in the end the same age and gender distribution was on either arm of the trial. That's what dynamic randomization means. So here's our sites. We included 6 sites that were geographically dispersed across the United States. We included UC Davis in Sacramento, California, here in Rochester, Indiana, IU in Indianapolis, as well as both University of Pennsylvania and Jefferson University on the East Coast, and Mayo Clinic, Florida, in Jacksonville. So we included patients that were similar to the interaction you just saw. So these are patients who didn't have signs of ischemia or heart attack on their ECG, and their first opponent was negative, and they had no known coronary disease. There's other high-risk characteristics that I've listed there that we applied when conducting the trial as well. Here's our list of outcomes. It's very similar to those that I just showed you earlier. In this trial, we also assessed resource use a bit more specifically, but otherwise we also measured patient knowledge and engagement and the acceptability of the intervention. So over 18 months, we enrolled 898 patients, and this is the baseline characteristic table that essentially demonstrates that the randomization process worked. These are selected patient characteristics, and the arms were balanced based on these characteristics as well as others that I haven't displayed here. So it increased patients' knowledge by, on average, approximately 1 post-encounter question related to their knowledge of acute coronary syndrome, their individual risk, and what their management options were. Patients were over 2 times more engaged in the process by their clinician. We asked patients about their experience using the decision aid. A greater proportion of those in the red bars, which is the intervention arm, reported that the information was more clear and that they would recommend it to their friends and family. We asked clinicians a similar set of questions. They also found the decision aid to be helpful. They said they would recommend it to their colleagues as well, and they wanted other decision aids for other emergency conditions. So there were some real disease or adverse outcomes in the trial, despite how low risk these patients are. There were 11 patients who had a percutaneous coronary intervention. There were 5 MIs, but we classified an adverse event as an event that occurred after a patient was discharged home that should have been picked up when they first came to the emergency department. So the ones in the top 3 rows all occurred and were diagnosed during the index presentation, so part of the patient's normal disease and treatment. There was 1 patient in the intervention arm who was admitted, who decided with their physician to be admitted, and when they were admitted, they had a stress test, a nuclear perfusion imaging test, and that was interpreted to be negative, and so they were discharged from the hospital, and they came back within 2 weeks with a non-ST segment elevation myocardial infarction. And this, our data safety monitoring board judged that this would have occurred in the course of usual care, and so they didn't attribute that event to the intervention. So similar to our original trial, multi-center trial suggests that the intervention is safe. So how did this one affect resource use? We similarly decreased our rate of observation unit admission for stress testing in the red bar or the intervention arm. We also decreased the 30-day rate of stress testing, and there wasn't a significant difference in coronary CT rate, but you can see it has a similar pattern compared to the other resource use elements. And so based on the findings of these 2 trials, we're now confident that use of the decision aid to facilitate shared decision-making in low-risk chest pain patients can increase patients' engagement and knowledge. It can safely decrease resource use. Both clinicians and patients found it to be acceptable. And when we actually compared the timestamps between the intervention and control arms, we videotaped almost 600 patients out of the 898. There was a 1.3-minute difference between the 2. So if clinicians are willing to spend just over a minute more talking with their patients, you can significantly decrease downstream resource use. Like whenever someone's admitted to the observation unit, like you have to figure out all their medications. There's a whole bunch of nursing care that goes along with that. And even among those who were admitted to the observation unit, there was an hour and a half shorter length of stay for those in the intervention arm. So I'm going to transition to pediatric head trauma. And why pediatric head trauma? So trauma is the leading cause of death in kids who are greater than a year of age, and TBI is the #1 cause of death. So it's something that is worth investing in and putting our time and resources in. And the controversy that we dealt with was, do we CT each of these low-risk children or not? And there's arguments for and against CT. If we CT all the children, we can pick up any unrecognized traumatic brain injuries. Kids that are less than 2 are frequently pre-verbal, and you can't really evaluate them very easily. And when it's indicated, the benefits of CT outweigh the risk. But there's also a flip side to it. Among kids who have CTs with moderate head injury, less than 10% have a traumatic brain injury that can be diagnosed on the CT. And among these that have a finding on the CT scan, less than 1% have a surgical treatment. You transport the kids outside the emergency department, you can increase their anxiety. Occasionally they require sedation. And then there's a theoretical risk of malignancy. And for these reasons, head CT has been highlighted as a top priority both by the Institute of Medicine as well as the Choosing Watson campaign. It's the #1 recommendation within the field of emergency medicine is to use validated prediction rules to avoid head CT in kids. And so we chose to develop a decision aid around this for that reason. Not only is it important from an epidemiologic and public health perspective, but there's also robust evidence that has previously developed a prediction rule. This prediction rules, the PCARM prediction rules, are highly sensitive for clinically important traumatic brain injury, and they have 2 rules, one for the pre-verbal kids less than 2, and those for 2 to 18. And then they stratify children's risk into 3 categories: very low, in which CT is not recommended; moderate, in which CT or observation are recommended based on clinician's experience and how comfortable the parent is; as well as the high risk, in which CT is recommended. This is a list of the characteristics. You don't need to obviously pay attention to all the characteristics. I've highlighted the 2 factors in both age-specific rules that will classify a patient as high risk. So if they're confused or have a GCS that's less than 15, or they have signs of a skull fracture, those are indications for immediate CT. The patient has none of these characteristics that are listed here. They're very low risk, you can send them home, but if they have any of these positive predictors, then the clinician's a little bit left in the dark. It's like kind of figure it out yourself, talk to the parents. But there wasn't real great guidance as to how to make this decision in the moderate risk group. So we developed a decision aid to help this decision, and you'll see some similarities with the last one. One of the things that came out to us is that there was a disconnect between the way clinicians think and the way parents think. And when we first started developing our decision aid, the clinician immediately started talking about clinically important brain injury, which made the parent think that whatever they thought wasn't clinically important, based on the difference in terminology. And also the parents, many of these are just focusing on does my child have a concussion or not. It doesn't necessarily cross their mind that we need to look for bleeding in around the brain. So we needed to traverse this gap, and so we initially would address right up front, does your child have had a concussion or not? And we can figure this out just based on history and physical exam. And then we transition to, is there bleeding in or around the brain? And that's what the clinicians care about. And we display what that risk is in a way that you can see there. We also show the parents what the decision is. It's either head CT or further observation in the ED and or at home. And on your right are the things the parent needs to feel empowered to look for. So if your child becomes less alert, they develop a headache, this is for the verbal children. If they have repetitive episodes of vomiting, they can't walk, or they have difficulty talking and recognizing people, do you feel comfortable bringing them back for that? And there was a frequently asked question training module that went along with this. So among those that were sent home, less than 1 in 100,000 returned anyway. And so we also would highlight that. It's like, because normally it's an emotional reaction. It's like, am I responsible for this now? Like, you can choose to be, but the likelihood you'll have to come back is very small. And then we just highlighted the different advantages and disadvantages of the two treatment options, and then had the clinician and the patient figure out what was most important, what they wanted to talk about, and guide their decision making. So similar to our last multi-center trial, this one also involved multiple sites. This one involved 6 sites. And we actually chose to randomize at the clinician level on this one rather than the patient level, because the PCARM prediction rules were so widely disseminated at that time already that it was going to be very difficult not to have contamination between the 2 arms. And so we took a group of multiple physicians, randomized them to either intervention or control. The ones that were randomized to intervention got trained, and the other ones didn't. They just got videotaped and had surveys performed. As I mentioned, we had video recordings obtained, as well as post-visit clinician-patient surveys. Here's a list of the sites that we enrolled patients from. And here's the inclusion-exclusion criteria. So a child had to show up within 24 hours of a head injury and have one of those non-high-risk factors present. That was the inclusion criteria. And you can see the several exclusion criteria there as well. So over 2 years, this is a little bit longer trial, we enrolled 971 patients, and we saw a similar direction of effect for each of the outcomes I've highlighted previously, including patients' knowledge, engagement, decisional conflict. Interestingly enough, we did have a significant increase in physician trust in this one, which we haven't observed in prior trials. That may be more of an issue with children, when parents bring in their children. Intervention was found to be similarly safe between the arms, and the only adverse event we had was in a patient who was admitted to the hospital, and they found out afterwards that there was non-accidental trauma involved. But the patient received appropriate care, but there was clinically important traumatic brain injury in that child. So in this case, the head CT rate was lower in the intervention arm, but it wasn't significantly so. But interestingly enough, we found that the average number of imaging tests obtained within 7 days of ED discharge was lower in the intervention group. So this is kind of some unexpected findings. And what do we make of those findings? And this is a slide that highlights each of the major findings we had. In addition to increased parental knowledge and engagement, acceptability for parents and clinicians, there was also a shorter ED length of stay. The ED length of stay was 20 minutes shorter in the intervention arm, and lower rates of imaging within 7 days, but not in the emergency department. And so how does this make sense? And so when you compare the 2 different settings, typically low-risk chest pain is usual practice in emergency care, is that physicians don't trust prediction rules, they just rely on their gestalt. So the introduction of the decision aid was really a bundled intervention and involved both assessment of the patient's risk, discussion of that risk, and then having that influence the decision-making process. Whereas with the pediatric head CT, they were already using the prediction rule, and we just now engaged parents in a different way. And to me, so if you're going to be introducing a shared decision-making intervention, it really kind of depends on what the current setting is that you're introducing it into. In terms of why we observed a lower head CT, a lower imaging rate within 7 days, we don't know for certain. We can hypothesize that perhaps the parents who knew more of their child's risk were less likely to seek repeat imaging after discharge. We didn't measure the reason why, but that's the best we were able to decipher at this time. And now it's onto the work, right? The real work, which is actually getting these used in practice. And so we've highlighted 2 different interventions that have multi-center evidence of effectiveness, and how we're going to go about getting physicians to use this and become part of what we do every day. And we recently submitted another application to disseminate and to implement our head CT, our chest pain choice for decision aid. And our proposal was to implement it in 2 emergency departments in the Mayo Clinic Health System, 2 in the Kaiser Permanente Health System. And since my transition to UAB, I proposed that we also tested down south in the University of Alabama, Birmingham. And the 2 emergency departments in both Kaiser and Mayo are conceived of as sentinel sites. If we can figure it out here, then we can spread it across our health system. If we can figure out the nuts and bolts of how to make it work on the ground. And UAB really has a high degree of diversity, so it's over 54% over 50% of the patients are minorities, so African Americans and Hispanics, and that'll be a nice challenge to figure out how to engage those patients in their medical care as well. And so as I'm planning out, okay, how are we going to make this work? What's going to be the strategy going forward? Does anyone recognize that individual in the right lower hand corner? Okay. So this is Simen Sinek. He's become famous. He's been all over YouTube. But focusing largely on the why. And as I highlighted earlier, emergency medicine formed as a specialty to meet a human need. And it was the commitment that we all have at this point is to treat anyone, anytime, anywhere. Right? But what the shared decision-making movement is pushing us to is to a higher standard, which is to treat each patient with dignity and respect. Anyone, anytime, anywhere, regardless of the cost. Right, so that's the why. And I have a full commitment to that. I don't think we should back down from it. It doesn't matter what the circumstances are, how busy you are. That's how we should treat each other as human beings. So that's the why that I intend to focus on. Now let's talk a little bit about the how. This is where it gets a little bit more involved. And I don't see Aaron Leppin here, but he has expertise in developing toolkits for dissemination and implementation. So we're going to develop a toolkit that not only involves our decision aid, but embeds it in the context of the clinical practice protocol, and involves videos like you've shown, as well as training sessions with the clinicians, and other elements of a toolkit as appropriate based on the input of the stakeholders. And then once we develop that toolkit, we're going to conduct focus groups at each of our sites that are involved of key stakeholders that can facilitate or block its implementation. And the strategy that I intentionally plan to engage in is to forge resilient relationships with each of those key stakeholders. And this is something that was handed off to me or taught to me by an individual who was helping me run up my HESIT choice trial. And he taught me very quickly, you need to get everybody's cell phone, because you need to be able to access them at any time. You can text them at any time, call them up as needed, and they may interpret that as a personal interaction. And there's things that I can do to intentionally leverage that relationship. And not only will I have to do it, but I'm going to have to also encourage and instruct the other site PIs as to do that with each of their key stakeholders as well. And then we're going to conduct these focus groups guided by normalization process theory, which I'll describe some of the details with in a minute. And then finally anticipate and weather the valley of despair. So this is, I won't go through the details of this, but this is essentially saying we're going to risk stratify patients into high, moderate, and low risk, and we're going to engage them in decision-making differently. With the low risk, they're going to be informed of their risk, and then the default can still be a recommendation. We don't think testing is indicated. Then the moderate and high risk, after they've ruled out for MI, do you want to get testing here, or can we follow up in the outpatient setting? And this is a protocol that's already been approved by our practice committee here and has had input from cardiology. And my point of showing you this is that we were really working on these details and have already developed a multidisciplinary protocol. So Michael Papanek is a gentleman that I've developed a friendship with over time. He teaches a course called Essential Facilitation, which is how you engage multiple stakeholders in dealing with complex content in which it's an emotionally charged situation and the outcomes matter. And so interacting with Michael, he highlights facilitation as a skill that you can learn to help guide groups through this decision-making process. There's other skills, what he calls soft skills. So there's crucial conversations, and there's emotional intelligence. There's different things that if your goal is to bring a group together, you can work on. We call these all soft skills. Because in the end, they can be helpful, but they won't be enough without forging resilient business relationships. And he has this diagram called the heat curve. And if you're sitting around a table with some folks or you're trying to work through a discussion, without authentic input, you're not going to figure out the problem. But the problem with authentic input is that it makes us all vulnerable. And we're immediately faced with something that we might not agree with. And his hypothesis, if you invest in these resilient relationships beforehand, the amount of heat that conversation among the group can take is higher. And so you're more likely to get to real authentic discussion without it breaking down and people yelling at each other, becoming passive aggressive, which is more commonly here. So before it disintegrates into people not talking and becoming passive aggressive, if you actually have everybody's cell phone number, you've invested in relationships, you've had coffee with them, they know the why, and they know you're committed to it, then you're much more likely to be able to identify the findings that you need to overcome in order to successfully implement the intervention. So this is Carl May's overview of his normalization process theory. And Carl's a lot smarter than me, and I won't walk through each of these elements in detail. But there's 4 major constructs called sense-making, participation, action, and monitoring. And this rubric or background is going to guide our focus groups. And Aaron, who is good with dissemination implementation with Carl May's input, will help us figure out these concepts and guide the discussion in a meaningful way. So this is the intended hopeful outcome of if you engage people in focus groups and you authentically gather and elicit input that can really affect the implementation of the intervention. So this top blue line is what normally happens. It's like, okay, the evidence supports a new clinical practice protocol. Let's just make it happen, right? And so there's all this effort that's involved, and then you finally get to a norm in which people accept it, and if you don't hit your ideal degree of implementation, but there's some moderate degree of implementation at the end. And the thought is that if you get the key stakeholders' input initially, and not only they understand the sense-making component, and you have the key stakeholders participating, but you have each of the team players come together and see what elements of this intervention can I uniquely perform that are closest to what I normally do in practice. So for our intervention, our nurses might do an element of the education, and our operations staff might systematically identify patients who might qualify for it, where ideally the physician could just walk in and say, click a button on the computer and walk the patient through. Because we had study coordinators with our trials who identified the eligible patients, who put in each of the risk factors, who handed the physician the decision aid. If we can get people to own this and have it adopt a new part of their practice together, hopefully the work of implementation is lower. But if you truly get their input, what we currently have constructed probably isn't ideal. How can it be optimized? And so at the same time as you're decreasing the work of implementation, you should be increasing the feasibility and appropriateness of your toolkit and your intervention. So that's the construct that Aaron and others have proposed. And I'm trusting he'll help me work through that as well. So this is when I talked about the VOD, or the Valley of Despair. This is what happens with pretty much every implementation project. And as going forward, anticipating there's going to be a VOD, telling people about the VOD, and forging resilient relationships, getting participation, buy-in, understanding each of these elements will help people recognize, okay, we're going to go through this element in which people are becoming passive-aggressive and not wanting to do the intervention, or maybe they'll say they'll do it, but only do it halfway so they can tell you it doesn't work. As they go through the VOD, hopefully we reach gradual acceptance by taking these strategic approaches to implementation.